the ACC latest guidance on management of hypertension. The blood pressure category of pre-hypertension is no longer used. Blood pressure should be confirmed by 2 or more readings that are made on at least 2 separate occasions. Individuals are classified according to their highest systolic or diastolic blood pressure category. New blood pressure categories are mentioned here. For ideal blood pressure measurement, there should be no conversation, an empty bladder, the use of correct cuff size, placement of cuff on bare arm, support the arm at heart level, and keep legs uncrossed and support back and feet. Recommended tests include fasting blood glucose, complete blood count, lipids profile, serum creatinine with estimated glomerular filtration rate, electrocardiogram, urinalysis and thyroid-stimulating hormone levels. Optional tests include an echocardiogram, uric acid, and urine albumin and creatinine ratio. Glycated hemoglobin may also be measured to detect prediabetes. Prescribed and over-the-counter drugs should be scrutinized for agents known to raise blood pressure such as anti-inflammatory medications, steroids, oral contraceptives. The new guidelines have separated the threshold for diagnosis of hypertension from the threshold for initiation of pharmacological therapy. High-risk patients, those with diabetes, chronic kidney, post-renal transplantation, known cardiovascular disease, or an atherosclerotic cardiovascular disease risk of 10% or more in 10 years for antihypertensive drug therapy when BP is persistently more than 130 systolic or diastolic more than 80 mHg. Secondary stroke prevention in antihypertensive drug-naive patients is the only high-risk comorbidity for which the 140 by 90 mHg treatment initiation threshold is recommended. Lower-risk patients are recommended for antihypertensive drug therapy when BP is more than 140 by 90 mHg. Adults aged 65 and older who are non-institutionalized, or community-dwelling and qualify for drug therapy when systolic blood pressure is more than 130 mHg, but no diastolic blood pressure treatment threshold or target was given for this group. Practice restraint regarding the intensity of antihypertensive drug therapy in older persons with life-limiting medical conditions. Suspicion for a secondary cause of hypertension have been listed here. Prescription of continuous positive airway pressure, as well as weight loss can lessen the severity of sleep apnea and associated hypertension. Adrenalectomy is the treatment of choice in those with unilateral aldosterone hypersecretion and those with resistant hypertension. Only consider renal artery revascularization if patient has refractory hypertension, worsening renal function and/or intractable heart failure. In patients with fibromuscular dysplasia, the recommended treatment is angioplasty without stenting. For individuals with white coat hypertension, elevated BP and stage 1 hypertension not qualifying for initial antihypertensive drug therapy, lifestyle and diet and recommendations are mentioned here. Most patients with stage 1 hypertension do not qualify for immediate drug therapy. Unless there is a comorbidity consideration favoring the use of a different drug class, pharmacological treatment is recommended to start with thiazide-diuretics, or calcium antagonists, or angiotensin-converting enzyme inhibitors, or angiotensin receptor blockers. In patients with systolic and diastolic blood pressure 20 or 10 mHg above target respectively, 2 drug therapy, either as a single pill combination or 2 separate pills, should be initiated. There is no current indication to initiate therapy with more than 2 drugs irrespective of the BP level in drug-naive patients. For treating hypertension in patients with comorbid conditions, the drug guidelines recommended are mentioned in this table. For treating hypertension in patients with comorbid conditions, the drug guidelines are discussed here. Individuals with normal blood pressure readings as well as individuals with white coat hypertension should be rechecked annually. Home blood pressure or daytime ambulatory BP monitoring should be measured along with office blood pressure. White coat hypertension transitions to sustained hypertension in 1 to 5% of patients with this condition each year. Those with elevated blood pressure should have repeat blood pressure measurements every 3 to 6 months. Individuals with stage 1 hypertension who do not qualify initially drug therapy should also have follow-up every 3 to 6 months. Patients initiating drug therapy should be followed approximately monthly for drug titration until their blood pressure is controlled.